So my name is Ben Sanford. I'm a physical therapist. Been a PT for 22 years. Today I'm going to present on total worker health, protection and promotion programs. I want to thank Chris for being my mentor, helping out. It's been really nice to meet you. Also had some really good discussions about the occupational and industrial world. I've been a PT, again, for 22 years. I've been practicing directly on site for 15 of those. So I work in a variety of different industries. Some would say that's kind of more of the heavy industrial realm. And looking at my presentation here today, basically kind of what we're looking at is kind of looking at some of the information that I presented about probably a month ago. I had the opportunity to work with Andrea Lausch, who is the Indiana APTA practice and policy payment specialist, and then an employer representative of ours, Sean Lane. We presented a lot of this information to the Indiana Employers Forum, basically looking at the value of PT and reducing musculoskeletal spend. Total worker health is defined by NIOSH as the policies and programs and practices that integrate protection from work-related safety and health hazards with promotion of injury and illness prevention, all in an effort to advance worker well-being. And again, I think the kind of the TWH model is really holistic and worker-centered. And if you go back, I'd say maybe 10, 15 years ago, I think maybe the focus was a little bit more on compliance and OSHA and things of that nature. I think with a new total worker health model, it looks a little bit more at global health, which I think is a good move. We kind of look at it kind of from the background, why? Why would us as PTs want to look at total worker health? Well, I think kind of what we're seeing is there's a big reason behind it, and it's basically a high incidence of musculoskeletal issues. For instance, musculoskeletal health is typically a top cost driver for most employers. A report by the U.S. Bone and Joint Initiative found 1 in 2 adults are affected by musculoskeletal conditions. And MSK conditions account for roughly a third of all patient volume across all medical conditions. And it's been estimated that 63% of these musculoskeletal conditions may be addressed with conservative care, such as physical therapy. Kind of looking at from a couple different silos, if you look at the group health spend, between 2008 2018, the average family premium and employer-sponsored healthcare increased by 55% to almost $20,000 a year, of which employers pay 82% of this on average. So again, it's becoming a big cost to a lot of the employers that we're working with. One in two Americans have had musculoskeletal conditions costing an estimated $213 billion in treatment and lost wages. And then perhaps a little bit of a soft cost that you really can't necessarily see in research is HR estimates that unexcused or unplanned absences can cost as much as 8.7% of payroll costs. So if we're having a lot of musculoskeletal injury, there's also potentially a lot of missed work because of those injuries. So again, it's a big driver for companies. Looking at the workers' comp spend, Institute of Medicine estimates between $45 and $54 billion annually. Looking at the BLS data, approximately 30% of all workers' comp expenses are related to musculoskeletal injuries. And again, these usually musculoskeletal injuries for companies account for those type of injuries that require workers to be off work for a period of time. So when we kind of look at who can help with this, I think us PTs we're positioned really well to be able to help companies with this. In some form or fashion, we have direct access now present in all states. As of 2016, all PT graduates are doctoral degree. Again, we're kind of the experts in diagnosing and treating MSK conditions. I think there was a study, I think it was in JOSO PT, that said PTs are equivalent with orthopedic physicians and being able to diagnose, and we're basically a preferred provider for diagnosing and helping treat musculoskeletal conditions. The APTA has been helping with obviously what we're doing here today, the Occupational Health Practitioner Certificate, and then through the PPS also coming up with direct to employer certificates. So there's becoming a lot more education, helping us PTs be able to standardize our practices and the way we go about treating occupational health. Looking at one kind of model that exists out there, this actually was a study basically done by Virginia Mason Medical Center. And what they did is they looked at being able to get anybody with acute low back pain into PTs within 24 hours. And they were kind of comparing this against the traditional method of treating low back pain. So if you kind of follow the blue areas on the screen, that's kind of the traditional method. A person may have an issue with low back. They may wait up to a month sometimes to get in to meet that initial doctor. Maybe it's a family doctor. From there, they may look at getting a referral onto a specialist, so probably a little bit more of a delay. From there, often they may go on for advanced diagnostics, looking at things such as MRI, X-ray, things of that nature. And then after that, usually the patient's going to follow back up with a doctor. At that point, if surgery is not maybe an option, we're generally going to look at a referral into PT. So there's this huge delay in getting patients into PT and that quick access. So kind of look at the red arrows. That's the kind of the newer model, looking at immediately seeing a PT. Again, best within 24 hours if possible. When they compared these two different kind of methods, basically found that kind of going the direct PT route saw greater than 50% total cost savings. We're looking at $900 versus $2,100. Again, 1 day versus 31 days, so patients were able to get in quicker. MRI utilization went down to 6% versus 42%. 94% of the patients did not miss work, and there was a decrease in the prescription medication by 73%. So again, showing that early access to PT can be very valuable. The challenge with it, I think, out in the current atmosphere of group health plans, especially, is the plan design sometimes impacts the ability for patients to want to choose or be able to have an early access to PT. So if there's out-of-pocket costs, this can drive patient preference towards conservative care. Okay, if you're looking at cost-sharing policies that don't necessarily align with clinical practice guidelines, and then what they're finding is basically with any type of barrier is going to cause a greater restriction on the provider choice. And usually that a lot of times will lead to a decrease in the choice of conservative therapy. So again, look at this kind of information. It gives us kind of a lot of the background of why we could have value in working with companies. On my next slides, I'm going to actually present an example of kind of how we started this with a company and kind of build upon a program to look at total worker health. This specific industry was a paper mill, had about 435 employees. The job work would be described as being physically demanding. It's pretty tough work. Also, it's very, very highly technical work. So our employees who work here are very skilled. They've had an immense amount of training and generally have a great deal of experience. So just thinking of that in that kind of context, if they're off work, it's really, really hard to replace them and replace their knowledge. And this company specifically had won the Governor's Safety Award in 2016, 2018, 2021. I kind of put that in there because to me, that says they have a good focus and a really care about their employees and trying to make the work easier for them. So when we started this program with the paper mill, we kind of did what I would call kind of a general assessment. Kind of how we got in the door is I had worked previously with a safety manager at another plant, and he had kind of taken a new job there. We initially met in the spring of 2015 to kind of discuss these musculoskeletal challenges and just kind of getting some of the background information. Kind of the paper mill's perspective of their people is they're a finite resource. They hold the knowledge and experience that makes them a leader in the industry, and they are the biggest investment of that organizations. They really want to be able to keep them healthy, keep them safe, keep them working well. And again, they look at their people as they're the key to the sustainability of that organization. They're critical. Looking at kind of our qualitative assessment of the paper mill's current status, employees in general were kind of an aging population. Again, they had that critical knowledge and skill. Jobs were physical demanding, and there was some concern that the aging employees may have some difficulty being able to perform the physical demands in a safe manner. Absence from work can really jeopardize, again, the paper mill efficiency, their production, their profitability. And they did have a desire to assess and, if possible, reduce the physical demands of the work. So kind of more of an ergonomic intervention. They also wanted to improve the employee knowledge of musculoskeletal risk. In a way, they wanted to kind of train the employees to be able to have kind of be little mini ergonomists and be able to flag things that could be a potential risk or could be difficult for them. And they also wanted to offer some early intervention for musculoskeletal issues to their employees. So again, it's looking more kind of the qualitative background, kind of more the interview and discussion with this company. Again, we kind of then looked into more of the quantitative assessment of the current status. So I always kind of put this quote up because it's really pretty true. In God we trust, but all others must bring data. So data is critical. You can look at most companies, they're going to be measuring all kinds of data, all kinds of metrics. So they may have financial metrics, such as EBITDA, earnings before interest, taxes, depreciation, amortization, gross sales, net sales, operating expenses. They look at a lot of quality metrics, scrap percentage, product failure rates, product specifications, scrap missed, product recall. Other production metrics: units per time, on-time delivery, operational downtime, maintenance rates, labor expenses. Again, a ton of metrics. But they also look at safety and health metrics as well. So some of the common ones I know that were discussed in, I think it was module 1. Some of the general safety and injury metrics, they look a lot of times at OSHA incidence rate, the DART rates, restricted days, days away from work, obviously work comp cost, and then cost per claim. Some of the general health metrics maybe looks a little bit more on the group health side would be their musculoskeletal spend. Also may want to work with the HR on looking at absenteeism and medical leave days, how many days employees are off work. And then also looking at potentially at planned cost per member. Again, I think a good goal working with companies to really kind of understand what metrics are important to them. What do they a lot of times look at? Because some companies can be different. This specific company kind of already had some of this quantitative assessment done. And this was kind of looking more at kind of the work-related side or work-related injury. So kind of the chart to the left, it's a little bit small, but it looked back from a period between 2010 and 2019. They're looking at top injuries, and this really included OSHA recordable injuries, but also included first aid reports as well. And basically 30% of their injuries were what they termed body mechanics. So as we kind of look down at the body mechanic injuries, these were really musculoskeletal injuries. They were strain, sprain, overexertion, sometimes cumulative type issues. And they also had a pretty good understanding that they really didn't know the physical demands of the jobs of what their employees were doing. Again, it's a big, large plant, a lot of different areas to cover. Looking at specifically at their recordable injury, that's kind of the graph or the pie chart on the right. Again, pretty similar to what we saw on the left. About 27% of their OSHA recordables were these musculoskeletal or body mechanic type injuries. So again, it was the leading injury category for them. So after reviewing the data, the qualitative and quantitative side, we kind of decided, working with their safety team, is that our initial approach would be to focus on the musculoskeletal injury side of injury. So we began with performing a job analysis of over 78 jobs. And these services kind of ended up constituting our phase 1 of musculoskeletal injury and prevention. And I'm going to kind of list them what we kind of brought in through phase 1. Again, first start, ergonomic analysis, job description development. From there, once we had that information, we could then develop job function matching. We specifically did it in 2 different instances: return to work and stay at work. We also generated a pre-work stretching program with them, and then also did a lot of training, employee musculoskeletal prevention training. Kind of the final component was helping kind of supplement their wellness team, being able to provide screens or be available for consult with employees through the wellness team. Looking at the ergonomic analysis, job description development, again, industrial-based therapists, we looked at 78 different job titles. And during this process, a real important side is we had the opportunity to engage with 125 employees, almost a quarter of their workforce we worked with generating these job descriptions and performing their ergonomic analysis. These ergonomic assessments looked at various things, like we assessed current workstation design, work practices, operating procedures to evaluate musculoskeletal injury risk. We also captured more quantitative data, push and pulling, lifting, carrying, standing, walking, climbing, looked at gripping, pinching, repetition. We used that information then to help write and create a job description. Once the job descriptions were complete, then of course we could use that as the basis for functional testing. And again, we applied this really in two different areas. One was stay at work, really for more high risk job classifications. Specifically, kind of really where we started was their emergency response team. They actually have almost kind of like a firefighting department on the plant site. And they use this to kind of requalify their emergency response team members every 2 years. They also did a return to work with type of testing for any employee who's off work 90 days. So if you've been off work 90 days, they come back in through a testing. And then one kind of attribute or one other kind of area that they could also apply it is if they had a company physician, if he felt the need for an employee to go to a test, he could request the testing for him. Again, the testing is developed from a validated job description, so it applies with the EEOC ADA compliance. And this was actually performed on site. They actually built an on-site kind of training testing center that we could perform this directly at the plant. Pre-work stretching was kind of our third portion of our phase 1. Again, we communicated these stretches through digital bulletin boards that were located throughout the mill. And the stretches were really developed from an understanding of the physical demands in the prior injury MSK risk data. So we kind of used our knowledge of the jobs to target the stretches that we thought would be beneficial for different areas of the plan. Looking at kind of the musculoskeletal prevention training, again, we were able to perform this training at their on-site safety training center. We kind of looked at really 3 different types of trainings. One was what we term body mechanics training, which is looking a lot at correct setup, looking at neutral spine, what's a good way to approach work in good positions to be in. Ergonomic awareness is, again, we were really trying to create a bunch of mini ergonomists. We wanted to train them and train their eyes to look at things and realize, hey, this could be at risk. This is above where we want it to be. And then we looked a lot at job task specific. These really look at the specific task of the different various jobs in the plant. Kind of look at the picture in the top right. That's what they call wheel valving. And in paper mills, this is a very common task. And there's probably 10,000 of these out in the plant. And they're located in all kinds of crazy different positions. So we really want to educate them on, hey, what's a good position? How can we change it? What can we do to make it safer to perform these type of tasks? And then employee wellness screening, again, partnered with their wellness team. And basically, they kind of helped incentivize this a little bit by offering points. If an employee chose to see a therapist, either for a musculoskeletal screen or just general musculoskeletal education. Generally, we do 3 kind of different screen types: range of motion, flexibility, they do strength, and also some balance testing. So that kind of completed our phase 1. Took about 4 years to get that stuff up and going. What we realized through this engagement with the workforce on phase 1 is non-work related musculoskeletal injuries were also prevalent. So we were kind of, again, really focusing more on the work injury side. But just from being out and talking to employees, non-work related musculoskeletal injuries were really, really common. And again, that led a lot of times to a loss of productivity or absenteeism. And then again, these plan member MSK issues also would have a potential to spill over and become a work-related injury. So it may be a little pre-existing issue that could lead to something else. We also realized that we needed to remove barriers from accessing the early musculoskeletal care for the plan members, because right now it's very difficult for them to get in and get treatment for it. And then we also want to look at offering an opportunity for employees to maintain MSK health and wellness. So again, a way to help keep them in good shape so they can continue to work and helps with the sustainability of the plan. Some of the kind of key points that the employees identified and some of the barriers. One is resources needed to be convenient and close. This specific plant, probably the closest medical provider was 30 minutes. So again, they would have to take off work, drive 30 minutes, spend maybe an hour, hour and a half, 2 hours, drive back. They'd miss at least half a day being able to go out and have any type of musculoskeletal provider work with them. Employees also made it pretty clear their time is very valuable. They're working 12-hour shifts at this plant, and having to attend ongoing medical appointments was not really desirable. And then also found basic conservative care was not often desired because, again, that time away from work, and also because there was a cost deterrent. Copays and deductibles. Again, man, every time I go to PT, it costs me this in a copay, and I have to meet my deductible. So again, a lot of times they just kind of set on the symptoms. Well, I'll just give it another month. Hopefully it gets better. Hopefully it improves. So again, we knew we had kind of some barriers for them to be able to get a quick access to musculoskeletal health. So this kind of led us to kind of what I would call phase 2. And this really started to look at basically looking at doing early and evidence-based symptom management and really looking at an on-site treatment clinic. So again, the specific state we work in has direct access. So we worked with the company in developing a location and building it kind of an on-site clinic. Again, this clinic was available for any type of early intervention. So if an employee had any type of symptom, we a lot of times could see them out there. Again, we're generally going through more of a first aid level type of treatment. And again, our therapists obviously had to be have awareness of the OSHA recordability standards. But we also wanted to open this clinic up for employee plan member non-work related PT treatment. So again, we'd have a clinic available and employees having an issue. We were sitting right on their physical plant location. We're right there, right outside their main gate. They can stop in and give them really, really quick access into a PT. And we used basically that plan again. Also, if there was a work-related injury, we could also see them and treat them there. Kind of looking at what their kind of plan design was. There's various structures you could set up with different employers. Maybe it's a cost. And again, we did this on what we call a direct contract. So it's not going through any insurance, strictly us contracting with the employer. We set it up on a per hour basis where we're paid for a certain amount of hours of being at the clinic. When we look at our targets, again, we call this kind of a hybrid model where we're looking at work-related and also non-work related. And we initially set it up just for employees only. So some other clinics that exist across the country, they can be open to all plan members. So that would be family members as well. We just focused on employees only at this time. And again, our big goals, we're trying to reduce obstacles and decrease employee cost and make it convenient. Kind of the overview, this clinic on site is really a fully functioning PT clinic. We've got virtually everything in there that we can do in our standard standalone clinics. It's built within an on-site fitness center, so we can transition really nicely from PT over to wellness. We have really convenient access. We're there usually 2 days a week, and we set up our hours to match when they're either coming in before work or working off work. So we're hitting it at what we call the shift splits, so we can get them right after work or right before work, so they're not having to wait around for an hour. So again, we're trying to remove those barriers. Again, there's no insurance paperwork, so less paperwork for the employees to fill out. And our PTs here are obviously very familiar with the work demands because we've done a lot of the job analysis work. So we can kind of speak their language, we can understand what they're doing, and we can really tailor the rehab to help them work and get back to work safely. And again, if it's for non-work, employees will usually access this clinic outside of typical work hours. So kind of looking at some of the outcomes from the paper mill. A little bit small, but if we look at kind of the chart, their data kind of started back in 2010. They had roughly 6 recordable musculoskeletal type injuries in that time frame. Our first 4 years, which roughly ran from 2015 to 2018, they had 2 that was kind of doing that work assessment job analysis phase. And then over the last 4 to 5 years, they've had 1 since we've opened up the clinic and had kind of the phase 2 put in place. What's interesting is our employee patient satisfaction, because we kind of basically surveyed that throughout the PT treatments, is 9.8 out of 10. So they really, really like having the on-site clinic. Look at some general other outcomes in just their general early intervention cases. We're usually finding between 85 to 95% resolution. And again, this is really right in line with what we see with all the other companies that we also do early intervention with. It's pretty typical to be in that type of a good outcome. As far as our on-site PT clinic, again, we technically opened the door in March of 2019. And basically, we run the data up through the end of last year, December 2022. We've seen 193 patients. 97% of these are non-work. We've roughly seen 1,490 visits. And during that time frame, COVID actually closed the clinic for about 10 months. So we really only have technically 3 years and 2 months of data. We've kind of been able to look at some of the cost comparisons to outside PT providers, and basically found up to a 53% reduction in cost per visit versus an outside PT provider. So it depends a little bit on the outside provider, but knowing some of the data out there and the cost, we were able to do a pretty good comparison with it. When we started this out, we also wanted to kind of look at our outcomes. So we use in our clinics a lot of times, and also now in the on-site clinics, we use what a term called photo, or a tool called photo. Basically looks at patient surveys, kind of take it before you start PT, take it after PT, looks at functional improvement. And this was kind of surprising in a good way, is the paper mill on-site clinic was ranking in the top 5% for functional improvement across clinics all across the US. And I think they've surveyed like 47 million patients. So it's a very, very large database. We also found that the paper mill, the on-site clinic, averaged about 3.5 visits less to treat a given condition compared to other traditional clinics. So it kind of made us think, why? I mean, why would it be so much better? And we really think it's attributed to that early access. I mean, again, they can get in quick. They go out, they have a little bit of elbow pain. They're probably going to see us within a day or 2, maybe 3 at the most, versus waiting a month, 6 weeks to get in and get it treated. We just find that, basically earlier treatments, it's responding much better. So a couple of our keys to success. We look at management support. That's obviously very, very, very critical. We also want to be sure we have a fully functioning PT. We want to offer a full service menu that helps draw in patients as well. We had to have the assessment of current MSK injury. We have to know where they were. Again, getting those metrics helps us. It helps prove and justify the existence of our on-site services. Education of the employees we have found has been very valuable. I think we've done a good job at that. And I think the employees have a much better understanding of musculoskeletal injury. And then again, really, really stressing that early intervention and action on the musculoskeletal symptoms and injuries. So that kind of wraps up my presentation. So think we can open up for discussion.
Hi, Ben. It's Rick Wickstrom.
Hey, Rick.
Let me go ahead and start my video. Thanks for that presentation. As a member of the audience, I'm with your patience. I'm going to give you a 9.8 out of 10 of satisfaction.
Great, thank you.
Yeah, it was a really well crafted presentation. I can see that you put a lot of time and effort into it, but it just followed a very logical flow. And I just, I'm a fan. So I'm in Ohio, not far from that, just across that Ohio River. So
Yeah.
I look forward to maybe the opportunity to do some further networking with you and also maybe engaging you in some of the Kentucky advocacy stuff that we're involved with. So we can talk about that as a sidebar. So,
Right.
but yeah, it doesn't surprise me that there's more non-occupational need in this company than occupational need. And I have a pharmaceutical company that I work with, and they might have 1 or 2 lost time claims a year with 5,000 employees, but they got 150 short-term disability claims, and just, I don't know if some of that is that it's easier for workers to kind of pursue their health complaints on the personal side of it or not. But I think return to work is return to work, and working productively and safely applies in either case. So
yeah, absolutely.
I found your data really interesting, and so
yeah, I kind of think you kind of look at it in 2 different silos, but especially as PTs, a musculoskeletal injury is a musculoskeletal injury, and is it work related, non-work related? Well, a lot of times it's probably a combination of both. Sometimes you'll see. So yeah, I think
and I was glad to hear that you're doing a wellness exam that is movement based. So that's pretty cool as well. So
yeah, well, thank you.
Yeah. So
yeah, we're actually looking at a screen. We're looking out to try to drive looking at some balance assessments out here, just because we know as we get older in our population, sometimes those balance reactions change. We're kind of looking at even some technology. So if anybody has any great ideas, please reach out to me or use something. We look at things like force plates and looking at that, because we just know that can be an issue. And the employees here, I mean, they're up and about, they're traveling in a lot of different areas. So we know that's something we got to be kind of cognizant of looking at.
Yeah, I'll let other people chime in, but great presentation. I appreciate it.
Hey, Ben, as far as the return on investment stats, do you have any of that information from the employer side?
We don't necessarily have the group health. That's one of the reasons we wanted to look at the photo. Their specific group health data is housed at a corporate level, and it's not really accessible yet by at the plant level. We're working actually with another company, working with this company as well, to try to get to that type of data, because we've done this with other companies, looking at work comp data as far as, looking at historical 3 to 5 years and then comparing it for return on investment. We just have to be able to get to this data, and it's not as easy to get to. There's some HIPAA stuff. There's a lot of stuff out there. It makes it a little tougher to get to.
Okay.
Yeah, when you said photo, I thought, that's outpatient clinic based kind of data. How, that's been one of my greatest challenge in doing worksite work, is to get to the sources of data that relate to work-related and non-work related injury, and to really get a sense for what the musculoskeletal spend is, since they are a population. If they're a big enough employer to be self-insured, then depending on who they're partnering with, getting that data and getting that trust relationship built up so that they'll share that information or provide data that gets at the musculoskeletal spend or the number of therapy visits and stuff like that. It just seems like it's always a challenge. We put these great wellness and other programs in place, and we don't have good year-to-year outcomes that we can track and trend.
Yeah, and I've worked with a couple of data analytic companies, and they'll generally tell you, for most industries, MSK in the group health is usually in the top 5, and a lot of times it's in the top 3, if not number 1. So it's pretty common to see it. We just can't. It's just hard to get to the data. Like I said, I think that's what we'll kind of focus on over the next few years, is really trying to get to that information. So
Yeah, we'll have to get you connected with the research committee and getting some dialogue starting along those lines, because I think if we don't prove our value as physical therapists, then we're going to be pushed out by, other cheaper sources of labor, such as athletic trainers.
Yeah, exactly. I mean, that's the kind of data, that ROI data, even if they are apprehensive about sharing the actual dollar numbers, just to share with you the percentage of cost reduction and total spend and things like that, then, that's just great evidence for promoting our profession and doing these direct to employer services like, what you're doing there.
Yeah, I don't, we haven't had a real difficult time getting to work comp data, because a lot of times we go to the basis, we need to have a benchmark so we can monitor and make sure what we're doing is actually working. So we just had a hard time getting the group health data so far. We're working on it. We'll see.
Other questions for Ben?
Thank you.
Okay, thank you, Ben.